Our second session is Managing PSC. I'd like to introduce our moderators. Dr. Christoph Schramm is the Foundation Chair for Rare Diseases at the University Medical Center Hamburg-Eppendorf in Germany. He's been involved in clinical and basic research on autoimmune liver diseases for many years. Dr. Schramm's scientific focus is on immune regulation in the liver and the pathogenesis of primary sclerosing cholangitis. Dr. Kidis Jimam is a board-certified transplant hepatologist and medical director of the Autoimmune Liver Disease Program at California Pacific Medical Center in San Francisco. Her clinical research focuses on cholestatic liver diseases and cholangiocarcinoma, with a particular interest in development and validation of prognostic markers of clinical outcomes in PSC. Thank you.
Our second session is, again, as introduced by Ricky, is focusing on managing PSC. I'm going to call our first speaker, Gideon Hirschfield, who is a transplant hepatologist and senior lecturer and consultant at University of Birmingham in England. Gideon. And the topic that he will be covering is looking after patients with PSC, the big picture approach.
Well, thank you very much for the kind invitation and for the opportunity to speak today. So obviously it's quite a tricky topic to give the big picture approach, and I looked at the talks that you had yesterday and the talks that you've had this morning and what you're going to hear. So what I've tried to do really is give you my big picture. So to start off with, I should of course give you my conflicts, and you heard Cyril talk about knowing where your clinician works. So I work in a large transplant program. We do 200 transplants a year. Around 25 patients with PSC are transplanted in our program every year. But at the same time, we see patients with PSC who don't need transplants, and we have a big focus on clinical trials, and I work with many industry partners, in fact, any industry partner who wants to do clinical trials in PSC. I was invited, fortunately, a few years back to give a talk at the PSC Partners meeting, and my recollection was that it was memorable. I really enjoyed myself. But there was another event on at the same time, which was the royal wedding. And you'll, of course, know that they've now got 2 children. So many simchas to them. Okay? And then this visit to the US is also very memorable. Okay? Because you'll know that, there's lots of things going on, but fundamentally, we're all still working together. And what I always take from these meetings is, for any of you who are classical Hebrew scholars, is the PSC Ruach, which means the PSC spirit, okay? Which is the spirit that you patients have to live with a difficult disease and to traverse the challenges that face you. So what is my vision statement? What is it that the big picture is? Well, what I want over the course of your journey, my journey as a career scientist, is better care targeted in better ways, encompassing quantity and quality of life. And the key attributes, I think, for effective PSC clinical management are informed and engaged patients and families. I think that's absolutely key. Accessible, knowledgeable clinical teams. Targeted care, addressing risk and unmet need. All of this integrated with clinical research, so the fact that you take part in some way is important. And our job is to help you manage uncertainty, because that's actually one of the biggest challenges of living with PSC IBD. And when managing uncertainty, what clinicians need to do with their patients is remember that we're not treating angels and we're not treating numbers, we're treating people. Okay? So every piece of investigation, every piece of knowledge that I acquire about you, from a blood test, a scan, whatever, is interpreted in context. And that's the key for managing such a difficult disease as PSC IBD. And the next thing is, and I encourage you to do this, and I welcome this for my patients, we have a PSC clinic every week in Birmingham, between 30 to 40 patients come weekly, and we encourage our patients to challenge us, okay? Challenge us and ask us questions. And if I don't know the answer, I'll tell you I don't know. Because we don't know everything, and that's the business of how you're going to manage the uncertainty, how you're going to balance the choices that you make. So, You've heard, it's a patchy disease, it's a complex disease, and it's got 3 significant components. Strictures, so it's a blockage disease, inflammation, and sadly, cancer risk. And cancer risk is real, but the majority of patients won't develop cancer. Now, that doesn't help the people who do develop cancer, but that still is the reality. And that's what we have to traverse. And of course, the uncertainty comes that when you have a disease which is a tubular disease, if the tube gets blocked, just like if the freeway gets blocked, it might have taken an hour and a half from JFK to New Haven last night, but on Monday when I go back to get to the airport, it might take me 5 hours. And I can't predict that, and I just have to cope with that uncertainty. And the other thing that's very important, that for the large part, in Caucasian populations of Northern European heritage, it is a bowel and liver disease. And as Tom taught you, we should think of it as PSC IBD for the large part. It is the same thing. So you've got this fibro-inflammatory cholangiopathy, and you've also got inflammation in the colon of all descriptions, from very, very mild to very significant. And what's the consequence of this inflammation is, of course, scarring. And we all know that treating scarring is very difficult. No dermatologist has yet got efficient treatment for severe burns, even when the burn injury has been taken away. And what you see in the slide is what's going on in patients with PSC IBD's bile ducts. There isn't any inflammation there anymore, you just see the scarring. And it's the scarring that's causing the strictures, the blockage, and causing the challenges ahead. Again, as part of this partnership between patients and clinicians is to remember that the colitis is distinct. We use archaic descriptions for colitis, ulcerative colitis, Crohn's disease, but they don't really describe what's happening in our patients. And we recognize that this colitis is different. Your gastroenterologist needs to recognize that. It's right-sided, it can be pancolonic, there is an increased colon cancer risk, but the inflammation can be very mild. And that needs to be recognized and factored into how you manage the patient, the big picture. The other part of the big picture, and that's why I'm so pleased that you listened to the first 3 talks, is to understand why people get PSC. It helps you to have some understanding of what it is that's gone wrong in your body. It's not your fault. You can't change many of those things. But it is a collection of genes, environment, age, gender, non-immune genes, and a healthy dose of bad luck. You're not going to take away the healthy dose of bad luck. The immune system, once triggered, once the genie's outside the box, it's very hard to get back in that box. And it's the trigger, and once the trigger's going, it's very hard to put the bonfire out completely. So it's a mosaic of risks that lead to the genesis of your disease. So what should the initial workup look like? Okay? Number 1, most patients, but not all, will have blood tests that point to biliary inflammation. Clinicians will use the term cholestatic liver biochemistry. So they'll see that biochemistry. They'll want to exclude other diseases. Those other diseases will be other bile duct. Some of them may be autoimmune diseases. Some may be very, very rare inflammatory diseases like IgG4-associated disease, which looks the same as PSC but responds to steroids. But you can clearly have the disease with normal blood tests, because blood tests are just one of the parts of the journey that we use to make the diagnosis. Then comes imaging. Now, this is where it gets controversial, but in essence, MRI is sufficient to make a diagnosis of PSC, and for the most part, endoscopic diagnosis is no longer recommended, and endoscopic therapy is only contemplated when either you think there's something you can do for your patient, unblock a stricture that you truly believe to be dominant and has appeared in the clinical context of clinical changes, or if you are pursuing the risk of bile duct cancer. People want to know about the role of liver biopsy. I'll come on to that in a second. Essentially, in most people's clinical practice, liver biopsy is not part of that practice, and liver biopsy is really reserved for small duct disease if you wish to make a secure diagnosis. If you're concerned about is the inflammation being driven by something that might be steroid responsive and so-called autoimmune hepatitis overlap, that might be an indication for a biopsy. But generally speaking, biopsies are now really reserved for clinical trials. And finally, nobody likes it, I'm told the prep is worse than the test, that colonoscopy is an essential part of your disease. It's a part of the disease surveillance, as Cyril pointed out. We need to know whether you've got IBD. We need to know whether you've got IBD now. And if you haven't got IBD, maybe you need to have that repeated in 5 years' time to see whether it's developed. And then you want a good quality endoscopist doing screening and using the latest test techniques. So I told you that we treat patients, not numbers. And liver tests are just those. They're numbers. Essentially, they are enzymes doing their business in the body, looking after metabolic pathways, that under injury situations to the hepatocyte or the bile ducts leak out, and we're able to measure them in your blood, and we use them to pinpoint the problem. It helps us to stratify your risk, but they are not the be-all and end-all. People do not die of liver tests, okay? It is helpful. And there was the question about, how do you tell someone what's going to happen to them in the future when you first diagnose them? We've learned a lot, and I'm not going to show this because we're going to hear some talks about how you so-called stratify risk. But if your liver tests don't go back to normal, if your alkaline phosphatase remains persistently elevated, then it's telling you something. It's telling you that you've got ongoing inflammation and scarring in your bile ducts, and no surprises, that is the group of patients with the greatest unmet need. That doesn't lessen the unmet need for other people, but in the order of priority, in the order of the way we design our clinical trials, that's the group of patients who've got the highest unmet need in the shortest foreseeable future. Something as simple as an ultrasound is good. Now, I know I'm talking to an American audience where everyone would like to have a CT or an MRI, but actually, as a jobbing hepatologist, I rather like ultrasound. It tells us an awful lot about what the liver looks like. I'm not really looking at your bile ducts. I can see your gallbladder. I can see whether there are any polyps. I can see the size of your spleen. Okay? That useful information, and it's now added to by the information we're going to hear about FibroScan, is actually very helpful in your journey through clinic. So an annual liver ultrasound is part of my practice to try and understand what's going on. And this always comes up. So we just talked about MRIs being very important for early diagnosis. We recognize that there's more patients with cholangitis than there are patients who end up needing transplants for PSC, so there's milder disease as well. So MRI is very helpful. We fundamentally do not have an answer to your question as to how often to have an MRI scan. Because, A, it's a difficult test. It's not great. I have had an MRI. And I did worry about whether the radiographer was going to come and get me at the end. And I was concerned whether I was going to bang my head on when I sat up. So it's not a great test, but it's bearable. But we don't know how often to do it. We don't know how to interpret them adequately. We've got people doing studies on them, how to interpret it. The clinicians can't even agree what they're looking at the moment. So it's not so clear to say having one every year is actually good for you. Okay? And fundamentally, I told you cancer's terrible, but the majority of you will not get cancer, okay? And the uncertainty of whether or not, you're needing the further investigations and the risks of ERCP need to be balanced out very, very carefully. In terms of liver biopsy, it's a day case procedure, it's safe, it doesn't carry that much more risk than colonoscopy, and it is informative, but informative predominantly at present in clinical trial settings. There was a discussion amongst people doing clinical trials as to whether or not, if a clinical trial asked patients to have 3 liver biopsies over 3 years, the patients would refuse to take part. Well, the answer is no, the patients did not refuse to take part, and the Gilead trial, which we'll report later this year or early next year, had 3 liver biopsies and was fully recruited internationally. So when there's a good rationale explained to patients, they will accept the risks because they can see the benefits. Because you can look at lots of things under a biopsy, and this, I'm not even sure if this is human liver, but it doesn't actually matter. It highlights the points about what are the important bits under the microscope. Okay? There's always lots of dark blue dots when you look at liver biopsies, but essentially you've got a bile duct. With every bile duct is an artery, and you've got a vein draining blood from the bowel, delivering lots of immunologically active molecules to the bowel that the liver has to look after. So we can see the damage going on to the liver, and we can see the accrual of scar tissue. And of course, what hepatologists want to do is avoid our patients having liver transplants. And for the most part, you have a liver transplant because you have end-stage liver disease, and that implies you develop cirrhosis, which is a series of stages over time. It's a progressive process. It's not just happening. Okay? And the goal is to identify when you've developed cirrhosis, to ensure that you've got appropriate surveillance for the complications of cirrhosis, but in addition, it also gives us the opportunity to develop therapies to prevent that from ever happening. And one of those significant complications in PSC patients, another test you don't particularly like, and I'm told many people actually prefer the colonoscopy to the gastroscopy, okay, which I can believe, is varices. But it's really important that we pick up our patients with varices with PSC and that we treat them promptly with beta blockade and we prevent our patients from having variceal bleeds. Because having a variceal bleed in PSC can jettison you in the wrong direction. It can upset the equilibrium and it can upset your liver, which then makes it a harder process. So I would encourage you to be up to speed with when your clinician says you need to have varices. Surveillance. Okay. So have we been doing anything for the last 20 years, looking for new drugs for patients? Well, the answer is we have, but it's been disappointing. And really, you don't need to worry about the details of the slide. What you can take from the slide, I'll give you the message of this slide. When we wrote this review for the Lancet, they told us to put it in the supplementary part of the article. They said no one's going to be interested in this table. There's nothing positive out of the table. Okay, so that's a sort of disappointing way to look at it, but it does give you the message that people have tried and haven't found the solution. A very important trial, which is actually key to one's outlook on how one looks after patients with PSC, always comes down to, do you take UDCA or not take UDCA? The answer from this clinical trial was clinical trials are important, that if you don't do the clinical trial, you don't get the answer, and that high-dose UDCA is definitely not the answer for patients with PSC. Personally, I don't use UDCA in my patients with PSC. The reason being is I look at all the different clinical trials that occurred. I look at this data here, which shows the last 20 years worth of liver transplantation in the UK for patients with PSC. I see no diminution in the final endpoint that counts liver transplantation in an era of UDCA. And I do not see that the average age of transplantation is going up for PSC. So I don't think it's having a sufficient impact. Okay, so what UDCA, no clear survival benefit. No evidence that UDCA will stop you getting colon cancer. The evidence comes from having good colonoscopy and having dysplasia screening. What happens if you've got overlap? Well, that's an individual thing between you and your clinician. You've got to be sure you've really got it. Steroids are good in some situations, but they carry risks. And your bones are important to you just as your liver is important to you. And corticosteroids will give you low bone mass. We've touched upon IgG4, but it's very, very rare. And I'm going to talk about symptoms in a second. A few important little messages that I think are important in that big picture is my patients have ciprofloxacin at home. I think Cipro is the same name in the US and Canada. Okay? So who wants to be struggling at 5 o'clock on Sunday afternoon to get their primary caregiver to give them a prescription for ciprofloxacin? You're all adults. You're not going to take it unless you need it. So it's in your bathroom cabinet. So if you're going to get symptoms of cholangitis, you can start the therapy. It may help you avoid going to ER, because if you go to ER, they won't know what your disease is, they won't understand it, they'll tell you you can't have antibiotics because you've not got a fever and your white cell count is normal, so you couldn't possibly have cholangitis. So it'll be wrong, 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 and wrong. So we'll bypass that, we'll let the patients take the antibiotics if they need them. You're a small group, it doesn't matter about antibiotic resistance in the broadest sense. Sometimes you need to rotate those antibiotics. We're going to hear a lot about endoscopy. It's a bit like, why is Europe such a difficult thing to decide about? Because if you asked 100 PSC clinicians on the role of ERCP, you get 100 different answers. Yet, we all still want to work together, but we're not going to agree one way of working. Okay? Transplantation, you're going to hear a lot about. When you need it, and we've talked a little bit about imaging. Beyond the liver, I think it was really telling at the FDA meeting when Ricky stood up and when Martine stood up to tell us about the survey of what patients tell you bothers them the most. And I now teach all my trainees the 3 things that your patient is thinking about in clinic is their pain, their fatigue, and their itch. Okay? It's real, and if you don't ask, you don't know. And we do have strategies, particularly around the pruritus. It's a lot harder around other things such as the fatigue to be perfect. For pruritus, again, you want a clinician who's active. You want them to know that they do have therapies, cholestyramine, rifampicin, and other things to talk about. PSC itch is a bit harder than PBC itch because I think Cyril talked about the way it fluctuates in general terms because it's a ductal disease. So we have a strategy for our newly diagnosed patient with PSC. We want to stratify them into risk and you're going to hear about some of those things. We can stratify risk around your history of colitis, your blood tests, whether it's small duct or large duct disease. We want necessary interventions at the right time. We want you to have antibiotics if you're having an ERCP. We want careful consideration before your dominant stricture is looked at. And we want ongoing relationship with your clinicians. And for the high-risk patients, hopefully you're going to go to clinical trials. For the low-risk patients, you're still going to be monitored. So I used this slide and I've adapted it. I used it at the FDA. I thought I'd show a bit of chutzpah, and the FDA didn't mind. So I believe we have a Mercurian approach to PSC, and the audience will be able to work out which Mercury we're talking about. So we, or you, are the champions, so don't stop us now. There's one vision, there's no wrong, and there clearly is no right. And I'm going to tell you there's no black and there's definitely no white. And we want it all. And if another one bites the dust, and I'm not talking about patients, I'm talking about drugs, then the show must go on. Thank you.